Assalamu alaikum. The topic of the presentation, you might see it too.
قرب المايك يا عمرو، قرب المايك.
I'm gonna present a 73 years old British female patient, chronic heavy smoker and alcoholic, non-hypertensive, 3 years ago on calcium channel blockers, past history of gastric ulcer. The patient presented to us complaining of repeated attacks of hematemesis. One day before admission, on examination on the day of the admission, the patient was fully conscious. Blood pressure was 160 over 100 millimeter mercury. Pulse was 100 beat per minute. Respiratory rate was 16. Temperature was 37. Saturation was 98. The patient has no stigmata of chronic liver disease, no history of non-steroidal anti-inflammatory drugs, no significant weight loss, no bleeding from other orifices, no symptoms of other organ affection. Clinical examination, head and neck was free. Chest examination was free with equal air entry on both sides. Cardiac examination was normal with normal heart sounds. Abdominal examination showed epigastric pain and mild epigastric tenderness. Neurological examination was free. Extremities were free. Laboratory investigations, hemoglobin was 12.3, hematocrit 37.9, INR 1.1, virology profile HPV, HCV, HIV were negative. Imaging, the pelvic abdominal ultrasound was free apart from chronic gaseous distension. The patient was scheduled for upper GI endoscopy, and upper GI endoscopy was done and revealed white membrane overlying hyperemic erosive mucosa of the esophagus, and this is the video. This is the membrane, and this is the mucosa underlying the membrane. And we put a differential diagnosis. The most probably it was esophageal candidiasis, or maybe HIV esophagitis, CMV esophagitis, HSV esophagitis reflux, or eosinophilic or Bell's esophagitis, or TB. But we had taken multiple biopsies for histopathology from the esophagus, and the histopathology comes like that. Widely ulcerated, focally desquamated esophageal mucosa, neutrophilic exudation with fibrin deposition, no malignancy, no dysplasia, no metaplasia. The conclusion comes erosive or sloughing esophagitis, or esophagitis dissecans superficialis. It's a rare desquamative esophageal condition. Presentations ranging from asymptomatic to be life-threatening symptoms. It is associated with autoimmune disease, drugs like potassium chloride, or non-steroidals, smoking, and maybe idiopathic. The diagnosis is a comprehensive clinical assessment, endoscopic assessment, histopathological assessment, and exclusion of the potential other causes. The treatment, no established standard treatment for this case. Most cases resolve spontaneously with no complications. And we take a home message from this: upper GI bleeding can happen due to a rare pathology. Thank you.